Thanks so much for tuning in. I'm interviewing Dr. Barry Singer. He is an MS neurologist as well as director and founder of the MS Center for Innovations in Care at Missouri Baptist Medical Center. He has been an investigator in greater than 35 multiple sclerosis trials focused on new therapeutic options, including remyelination. He really knows his stuff. And in today's episode, we talk about symptom management for fatigue, pain, and bladder. This episode is chock full of his best recommendations for therapies and medications for these specific symptoms. You'll definitely want to take some notes or just come back to this for future reference. Okay, let's dive in. Dr. Barry Singer, thank you so much for being here with us today.
All right. I'm happy to be here. Thanks so much, Dr. Holly.
Of course. So I've got a lot of MS symptom management questions for you, but before we dive in, is it okay if I ask you a question from my interview deck?
All right. Wild card. Here we go.
Yes. All right. Your card is, do you have an area of your life that you are never satisfied with?
Hmm. Area of my life. Well, I'm kind of a painter, actually. I've been painting since I was a boy and love to paint. And so I work too much. So unless I start painting at 3 in the morning. So yeah, that part of my life, I'd like to get back to it, get to these more frequently.
I love that. What type of things do you typically paint?
Using oil, so tend to be like kind of twists on still lifes.
Oh, very cool. Nice. All right. So let's just go ahead and dive in. So, honestly, with the MS symptom management, I feel like we could talk for days about ways to manage symptoms. So, I have a few specific ones that I want to talk to you about.
Okay.
First and foremost, what are your thoughts on fatigue and best practices to manage fatigue, since that's one of the most common symptoms?
Yeah. So question. Yeah. So over about 90% of people with MS live with fatigue. And so one of the important things if you're going to address fatigue is what type of fatigue is it? So it could be motor fatigue. You deal with this in the world of therapy. So if people are their legs are weak, it takes a lot of energy to get from point A to point B, you get worn out, physically worn out. But the more common fatigue is actually like you didn't get enough sleep and you really feel like really tired, like you're drowsy, didn't get enough, you don't feel perky enough. And it can be overwhelming. I mean, some people get up in the morning, they take a shower, and then they go to lie down in the bed because they're just so worn out. And so that's the overwhelming fatigue that a lot of people, family members don't get, friends don't get sometimes how much that can be, how debilitating that can be. So we will look at a different ways of trying to address that. So some of them, we try to look at, first of all, is a person getting enough sleep? So that's a huge issue with a lot of patients. Some people are just anxious. They can't shut it off. Their brain is going round and round and round, trying to solve everybody's problems at night or what happened during work that day. So we really work on that. Restless legs is a big issue. So some people kind of move their legs around. Sleep apnea is very common. Going to the bathroom numerous times at night, leg spasms at night. So we really have to address good sleep. And then once you have good sleep worked out, then you have to kind of think about your schedule. And we talk about energy conservation. Another way of looking at this is the spoon therapy, the spoon theory. You have a certain amount of energy, certain amount of spoons each day, and if you use them up too early, then you don't have any gas later in the day. So what we want to do is focus on trying to do those physical activities in the morning, give yourself a break midday, and then maybe some lighter activity later in the day. So kind of spreading things out. If you work all day, can you spend 15 minutes or 30 minutes of your lunch break just resting and relaxing? Can you take a nap in the middle of the day if you're, not working? Those would be all approaches, non-pharmacologic. And then we really focus on if that doesn't work, then we do have some medications that work. And so none of these are really FDA approved for the treatment of fatigue. I tend to use modafinil or Provigil or armodafinil or Nuvigil first. I find them well tolerated and they generally work well for patients. Amantadine's an old generic medication. I give it about 50-50 if it can work. It's got some side effects, including kind of a mottled rash in the legs and some leg swelling. And then if we need to, sometimes the amphetamines can make a big difference, Ritalin, Adderall. So we try to stay away from the medications if we can. Some cognitive behavioral therapy has been shown in clinical trials to really work well for fatigue. So there's growing literature on using that as a strategy, which is a great non-pharmacologic way of treating fatigue.
That's really helpful. And I'm glad that you started with differentiating between the two different types of fatigue because there is a difference. And I love that you mentioned that people without MS don't fully understand. It's a very different type of fatigue than what someone without MS would experience.
Yeah,
So,
I find that really is very frustrating too, for people living with MS because people don't get it, like you have to cancel because it's just a bad day for you. And sometimes people just don't understand it. They say, oh, you look great, but they have no idea you're dealing with burning pins and needles and bladder problems and word finding
yes.
difficulties and all these different symptoms that you can't see.
Yeah. And so I was at the annual MS conference back in October from the CMSC, and sleep was a huge topic. And they mentioned the cognitive behavioral therapy. And it's so true when you're not getting good sleep, any of your symptoms can worsen, but especially fatigue. So if someone's listening to this and they're thinking, oh yeah, my sleep is awful, is that something they should go to their neurologist about first or a sleep therapist? Where would they go to start this journey?
Yeah, I think the first place is you can go to your neurologist. I mean, I think we're pretty good at addressing that. So we can sit down, talk about what are the issues. Which one of those aspects that we talked about is a restless legs. A neurologist can treat that. Spasms or bladder problems, we can address that. Maybe we'd send you off to a urologist if it was bad enough that we need some help there. Sleep clinics definitely can be an option. So that's how you would kind of diagnose obstructive sleep apnea. Restless legs during sleep is called periodic limb movements of sleep. So those are things that you can, getting a sleep specialist can sometimes help. But usually your neurologist, MS docs in particular, are pretty well versed on it. And frankly, most general neurologists do a lot of sleep management.
Awesome. That sounds great. Okay, so next symptom is pain. And this is another one where there's so many different types of pain. Can you first explain what the different types that you most commonly see are, and then some strategies to reduce it?
Yeah, so there's a lot of different types of painful syndromes. I guess we can start from the top of the head and work our way down. So one of them, one of the most painful conditions is trigeminal neuralgia, which is a sharp shooting electrical pain, sometimes lasting a few seconds, 30 seconds or a minute at a time, like a shock. And it can be radiated into three distributions. One is across the forehead, one is into the cheek, and one is into the jawline. And there's three branches of the trigeminal nerve. And sometimes it's the whole side of the face. It can be on both sides, but typically one side. And it's just this excruciating electrical pain. People that have had natural childbirth and also kidney stones, they say this is worse. So it's pretty
Oh my
severe.
gosh. Yeah.
And it's electrical pain, and then it may be some lingering pain afterwards, and it can occur multiple times a day or even an hour. Some people have gone to dentists if it's in the jawline and have had teeth extracted, so kind of barking up the wrong tree. So that responds, if an acute episode, then we would treat it with steroids, IV steroids as a relapse. But if it's ongoing, then we look at medication. So there's quite a few meds that we use, things like Neurontin or gabapentin, something called oxcarbazepine, also known as Triluptal, or carbamazepine, which is known as Tegretol, or some of the medications. But we do have an array of medications that can help reduce that pain. Sometimes we have to work through the list. If it doesn't respond to that, there are some neurosurgical procedures that can really provide significant relief. So I've had patients where that worked well for them. So that's up in the head. And then we move on down. So one of the bad problems that we have with MS is some people get the MS hug, which is a squeezing pressure around the torso. It's not a comfortable hug. It's like a bear hug, the squeezing. And some people it even catches their breath. And so we use kind of a mix of options there. And one of those things that we use is muscle relaxants. For example, baclofen, tizanidine sometimes helps. And other patients seem to respond better to nerve pain medications such as gabapentin or Lyrica, which is pregabalin. So those medications sometimes help with the MS hug. And then a lot of people with MS have burning pins and needles pain. So that could be anywhere. It could be one side of your body. It could be your legs down. And so that can be very painful, burning pins and needles, tingling. And that really responds pretty well to nerve pain medication. So again, they tend to use drugs like gabapentin or Neurontin, pregabalin or Lyrica, and then duloxetine or Cymbalta, which is an antidepressant medication that works really well for nerve pain. So I've been very happy with that medication. Sometimes chronic nerve pain causes depression. So if you have one medication that controls two things, that really helps. So most of the nerve pain medications are kind of the way we go with that. It's hard to do that non-pharmacologically, deal with nerve pain. I mean, if it's not bad, you can put up with it, but eventually it might hit that threshold where, it's great to get that under control.
Wow, so lots of different options. So does it normally work kind of the same as most pharmacological agents with insurance companies where you'd have to start with one, see if it works. If it doesn't, you can move to the next one?
No, generally we can get these approved. So, usually we can get them through. I mean, occasionally insurance plans a little more restrictive, but these are all generic medications. So, and they've been around for a while. So usually we can get them, and they all have potential side effects. So you kind of look at what makes sense between you and your provider. And if those don't work, there's other medications that we work through, like amitriptyline, Topamax, Capra. So there's some other medications that sometimes will work for an individual. And so that's really important. Now, another painful component is muscle spasms. So cramping or tightness in the legs. So we definitely focus on stretching for those people, muscle relaxants. So it can help. And actually, there's some data even on cannabis in terms of mixed THC, CBD, and helping muscle spasms and multiple sclerosis. So that can be quite painful. But physical therapy and stretching can make a big difference. Massage therapy can help with the spasms. There's one type of spasm that's really bad, and they can either be, we call them flexor spasms, where your arms get flexed up, and then extensor spasms where the arms or legs shoot out. And those kind of spasms can be very painful. And sometimes the seizure medications such as oxcarbazepine can help with those, but that can be these spasms can come on and be quite severe. So again, if you're having pain from MS, it's really important to talk to your healthcare providers about, what are the options out there?
Yeah, and it sounds like there's a ton of options. What are your thoughts on tremors? So, as a physical therapist, I work a lot with muscle spasms and tremors. Can tremors be caused from the MS itself, kind of like primary tremors versus muscle weakness or spasticity?
Yeah, so we definitely see like the most common tremor that we see in MS is a cerebellar tremor. And so what this is basically when you go to reach for something, someone's arm goes back and forth. So you're reaching for something and it just kind of goes back and forth while you're trying to grab something. And we call that an oscillation. It's kind of a back and forth. And that can be very disabling. Sometimes it's associated with poor balance. Someone stands up and their balance is off. So that's kind of the most common tremor. If you're weak and overexerted yourself, then you might get a little shaky. But in terms of tremor, we tend to see that with that. Now, there's a benign tremor called benign essential tremor, which is a mild little hand tremor where your hands jiggle a little bit. And that's sometimes unrelated to MS. And so I find that pretty commonly out there in the general population. So people with MS may have another condition that could be treated. So we definitely look at options to try to control the tremor.
True. Yeah. It's very rare that someone just has MS and no other comorbidities or different diagnoses, at least from what I
Well,
see.
particularly as you age,
Yes.
a lot of my young patients don't have any other medical problems, but
True.
unfortunately, things tend to add up over time.
Yeah. So, my final symptom management question for you is about bladder. This is another symptom that often goes unnoticed to the public because you deal with it kind of in private, but so many people that I work with who have MS have some type of bladder issues. Similar style here. Can you explain the differences and then what we can do?
Yeah, so there's a few different types of bladder symptoms that people with MS have. And this is also very common. One of them is bladder urgency. So when I got to go, I got to go. So when you got to go, you got to really run to the bathroom. And if not, you could have some leakage, requiring a pad or sometimes incontinence. And of course, this is magnified if you got mobility issues. So, if you use a cane or a walker and all of a sudden you got urgency, it's a lot harder to get to the bathroom quickly. So again, we try to manage it without medications if you can. So caffeine will make it worse. Some people drink less water, but it can cause some constipation. So we kind of have to watch that a little bit. But planning, going to the bathroom before you get in the car, planning things out can make a big difference. And if it doesn't work, then there are some medications. There's two classes of medications that can help. One of them is they're called anticholinergic medications, and they include things like oxybutynin, which is like an old one, sulfinicin, and so these are medications that can help with the bladder and really slow down the urgency. So they can make a big difference, keep people dry. So they really help. The anticholinergics that sometimes cause dry mouth and may potentially impact memory. So that could be a concern if you're already having significant cognitive problems. There's another drug that's only brand name called Myrbetriq, and Myrbetriq works differently. So it doesn't cause that dry mouth, but sometimes can cause an increase in blood pressure. So we use those for urgency. If that doesn't work, Botox is a great option for some patients. And so the bladder could be injected with Botox and works for 6 months in general. And so the urgency goes away and you don't have to take medications regularly. If it works too well, though, you may have trouble voiding initially, and you may have to do self-catheterization for a short period of time. But many of my patients that have gotten Botox feel great afterwards, and they're glad they finally did it. So the usual comment is they should have done this 10 years ago. So, so it's a good option. Now, other people can't empty their bladder completely. So if you have trouble emptying the bladder completely, then you're retaining urine. And you kind of think about a bowl of water. If you laid it out on your counter for a couple of days, you're not going to want to drink that, right? Because the bacteria would overgrow. Well, the same thing happens to the bladder. So if you're not emptying completely, your bladder is full, then you got your bacteria can overgrow. And as a result, that can lead to recurrent UTIs. So the treatment for that sometimes is medication, but generally people that are retaining and end up doing some self-catheterization. So it's a sterile disposable catheter that you use maybe 4 to 5 times a day, and it empties the bladder completely on demand. And that stops frequently it stops the UTIs. Now, some people are mixed. They have trouble emptying plus bladder urgency. So the urologist can help sort through that and figure out the best treatment approach.
Wow. So, what I'm hearing from our entire conversation is there's a lot of hope. There's a lot of options out there. And as long as you bring up these symptoms to your neurologist, you should have many things to work on. And, maybe you start with one, see how it works, and then transition to something else.
Right. And like anything else, I mean, we try to avoid medication or intervention unless we need it. And
Right.
so, you don't want to take a pill for every MS symptom. We have a lot of different symptoms and a lot of different treatments. So you pick what things are really driving your quality of life down. And if it's a bladder that's keeping you up at night, so you don't get enough sleep, and then you're tired at work and you can't focus, and it's affecting your memory, then let's fix the bladder. So we've tried to find which symptom is really driving a lot of the impaired quality of life. And once we can fix that, a lot of times things are much better. I can think of a lot of people where I improved their nerve pain And so their quality of life just shot right up. They feel great. So that's really important. So really prioritizing what needs to be fixed first is what we can do. And most symptoms we can address. I think the hard one that we have is a cognitive impairment, so memory problems, processing information. That's probably our most challenging symptom because we don't have a quick fix for that one.
Yeah. And as you mentioned too, if you can fix one, sometimes others automatically improve. Like as we were talking in the very beginning, if you can improve your sleep, your fatigue might improve, your spasticity might improve. So as
Right.
you mentioned, focus on one first and then see where that leads you.
Yeah, exactly right. And that's what we generally do. See which symptoms are really driving the problems. And for a lot of people, it's the fatigue issue. So if we address fatigue, they can exercise more, feel better, perform better at work, or be able to take care of their family more, able to knock out some laundry instead of taking a nap. So it really makes a big difference.
Awesome. Well, this has been so insightful. I have learned so much, and I know that our listeners have learned a lot as well, and even maybe thought of new conversations that they can have with their healthcare providers. So, thank you so much for your time and your insights. I know that some of our listeners are probably going to want to know where they can find you and continue learning from you. Can you tell us a little bit about where they can find you?
Thanks, Gretchen. So, a few different ways. So, the website that I actually created for patient education is called mslivingwell.org. And I started in 2007, and it's been a resource on there. There's information about managing symptoms, like we were talking about, understanding your MRI, understanding the disease, blog section, as well as links to the podcast. So, the podcast is called MS Living Well. And I started it about 4 years ago, and I interview over 50 people in at this point, and about different things. Some are symptoms of the disease. Last one was on aging in MS. I have one on diet just recently, and I tend to interview like leading global experts in the field as well as some patient advocates. But generally, global experts in that particular area. Recently, one on Epstein-Barr virus with Alberto Scaria, who actually did the research on Epstein-Barr virus as a trigger for MS. So it's been great to get my colleagues and some of our great patient advocates on. And really, it's about providing information, just like this session, to people living with MS. And then I'm also pretty active on Twitter. So at Dr. Barry Singer, you can follow me there.
Awesome. And I will put all of those links in the show notes. And I've just got to say, too, your website is amazing. There's a whole section for the newly diagnosed, and then there's a separate section for understanding MS, what to expect. So it's a great resource. Your podcast is so varied, so many different types of conversations that are important to learn. So I am a huge fan of everything that you do. So thank you so much for talking to us today and sharing your insights.
All right. Well, thanks, Dr. Hawley. Thanks for all you're doing to educate the MS community, and that's really the goal. Knowledge is power, and I believe that strongly over my career. Is that patients that are more informed, people living with MS are more informed, make better decisions for themselves and better advocate for their healthcare.
Absolutely.